Hello, y'all, and welcome to Professor Truelove's Concept for Nurses series. And the concept reviewed will be problems of the brain. I am Professor Terry Truelove, and in this episode, one of the neurological episodes, we're going to be discussing headaches, cluster headaches, migraine headaches, and even secondary headaches, their sources, and their treatments. This is the first of the neurological episodes that you will be listening to. You should know that the primary sources for the information that you're about to hear is from Iggy's Med-Surg Nursing 9th edition and sometimes from Soul, Introduction to Critical Care Nursing 7th edition. So, headaches. Headaches are also known as cephalalgia. A headache is the condition of pain in the head, which is caused by a stimulation of pain-sensitive structures in the cranium, head, or neck. Most of us suffer from some type of headache during our lifetime, and this can be from a variety of causes, such as low blood sugar, sinus infection, alcohol, and stress. These headaches are acute and temporary, and often resolved by managing the cause of the headache, and or by taking mild analgesics, such as acetaminophen. However, in some cases, some adults have specific types of headaches that cause severe, debilitating pain and recur. The most common type of these headaches is called a migraine headache. This type of headache is most likely to affect quality of life when compared to other, less common types of headaches. A migraine headache is a common clinical syndrome that's characterized by recurrent, episodic attacks of head pain that serve no protective purposes. A migraine headache is a chronic, episodic disorder with multiple subtypes classified as a long-duration headache because it usually lasts more than 4 hours, and it is characterized by an intense pain in one side of the head that is unilateral, which worsens with movement and occurs with either photophobia, that is sensitivity to light, or phonophobia, that is sensitivity to noise. Now, for the rest of this podcast, I'll be using a voice that you should be using when you're dealing with patients who suffer from headaches. Try to reduce the stimulation. Migraine headaches tend to run in the family and probably have a genetic basis, although vascular, neurologic, chemical, and environmental factors may also be involved. Abortive therapy alleviates pain during the aura phase, or soon after the start of the migraine headache. The priority of care for the patient having migraines is pain management. Drug therapy is prescribed, but complementary and alternative therapies such as yoga, meditation, massage, exercise, biofeedback, ice, a darkened room, and relaxation techniques may be helpful. Drugs used may include triptans, ergotamine preparations, and anti-epileptic drugs. Caution is warranted with opioids and barbiturates for pain control because of their addictive nature and because some opioids can actually exacerbate or cause migraines. Both calcium channel blockers and beta blockers are used in the treatment of migraines by interfering with vasodilation, a contributing cause of migraine pain. Both beta-adrenergic blockers and calcium channel blocking drugs can lower blood pressure and decrease the pulse rate. Teach patients with migraine headaches about triggers that could cause an episode, such as caffeine, wine, and pickled or aged foods. To review, in order to properly care for the patient with migraines, you need to understand how the timing and duration manifests itself, including key features such as the phases with aura, including first or prodrome phase, the second and third phase, and even remembering that there can be migraine without aura. Have the patient describe the type of pain they're having that will help you to diagnose and differentiate between migraines and clusters. Look for other symptoms, including nausea, factors that started the migraine headache, the causative factors, Current therapies the patient may be taking. The priority of care, remember, is pain control and teaching to avoid any triggers. Pain of cluster headaches is described as excruciating, boring, that is, driving through like a drill, and non-throbbing, and is usually accompanied by ipsilateral eye tearing, rhinorrhea or congestion, ptosis, facial swelling, eyelid edema, and miosis. You should teach patients with cluster headaches about precipitating factors such as anger episodes, excitement, and excessive physical activity. To review, differentiate cluster in migraine headaches by, again, reviewing the timing and duration of the headache itself, how the pain is described, where and whether it's bilateral, unilateral, other symptoms that go along with it, any causative factors, that is, the triggers, any current therapies the patient's on. The priority of care, like migraines, is always pain control and therefore medication teaching, and again, patient teaching to help the patient avoid the triggers that cause these headaches. One of the more important interventions for the nurse to remember is simply noticing that the patient is starting to have the symptomology associated with migraine headaches, and then being able to assess for what those symptoms mean. Drug therapy is important, remembering that new research from the 90s indicates that this is probably involving afferent nerves and could even involve the trigeminal nerve when we're talking about migraine headaches. So drug therapy is going to be directed at reducing those pain stimuli. And this is why complementary and alternative therapies work so well, because by causing calming, by inducing calmness to the patient, it's a great way to reduce the stimulus of those nerve bundles that are causing the migraine headaches in the first place. And the importance of differentiating the different types of headache comes clear with this slide, because secondary headaches are the result of other pathological conditions, such as aneurysm, brain tumor, or even inflamed cranial nerves. This headache is caused by compression, inflammation, or hypoxia of pain-sensitive structures. And this means that the interventions are going to be very different from cluster or migraine headaches. For any of these headaches, advise the clients to keep a diary of headache history to ascertain any patterns. To continue to avoid, or try to avoid, do their best to avoid any foods or other substances that can trigger their headaches. Some suggestions that may or may not be valid include reducing salt intake. That's under a lot of controversy, but practicing relaxation techniques has proven effective in both cluster and migraine headaches, and relaxation does promote pain control. So I would submit that for any headache, having the patient relax and practice relaxation techniques is an effective intervention. Thank you for listening to this podcast, and please continue on to the next podcast where we continue our neurological series for nurses. Take care.